Hi, everyone. Thank you so much for joining this session on the data that shapes global health. So this session is going to try and break down specifically how this data helps to shape policy and how this impacts journalism, industry, and other areas. What are some of the things that we should know about how this data is collected and how this data is analyzed and all these sort of metrics? And some of us are curious, where does this data actually come from that we see online or on the website? So to help us break down this very, very interesting discussion and session, we have Saloni Dattani. Saloni is a writer, an editor, and researcher who's focused on health, medicine, and meta science. She is a researcher at Our World in Data. And I think you remember from the COVID pandemic that this was like the #1 source for data on COVID-19 statistics. So she writes about trends in global health and the data behind them. She's also a co-founder of Works in Progress, a magazine that explores ideas for improving the world. Her writing blends accessible narratives with a deep understanding of scientific methods and public policy, often on topics including medicine innovation, clinical trials, and demographics. So help me to welcome Saloni Dattani to the stage.
I want to start by showing you this graph. This is a graph of tuberculosis cases in Glasgow in Scotland in the 1950s. And you can see there's this very slow decline in the early 1950s. Suddenly something happens in 1957, and then there's a big drop, and the decline in tuberculosis speeds up. And you might be wondering, what happened in 1957? Well, in 1957, there was a mass screening program for tuberculosis. More than 700,000 people in the city of Glasgow were screened for TB using miniature x-rays that were traveling around in little vans. People were given prizes if they signed up for the screening campaign. And you can see the decline was likely because of early detection of tuberculosis and subclinical tuberculosis. Because of this early detection, it meant that people could be treated sooner and isolated sooner from other people, and that likely rapidly reduced the transmission of the disease. So the short, intensive push for data collection changed long-term TB control in Scotland. But usually the value of data is quite difficult to measure. Not every city gets a natural experiment like Glasgow did. It's tricky to measure the impact of data because not everyone cites the data that informs their decisions or their thinking. There's also a chain reaction. Someone who does research might influence journalists or other scientists. That influences other advisors or managers. People read that stuff, and they don't know where exactly the initial point started. There are just so many different users of data and so many different uses that it could have. Ministries, startups, NGOs, scientific researchers. It's very difficult to count up all of the different uses that data can have. But despite this, I think that we can say that data has been really important in making a difference in global health and in public health. There's some examples here. I just want to point out a few. Maybe you've heard of Semmelweis. He identified a large reduction in maternal mortality rates in maternity wards that were staffed by nurses instead of doctors, and it eventually traced this to their hand washing habits. There's also John Snow, who traced the outbreak of cholera to a contaminated water pump in London. And there's Florence Nightingale, whose charts you might have seen before. She analyzed data on military deaths and found that the vast majority were caused by infectious diseases, and this led to sanitary reforms in military hospitals. So this brings me to what data can actually bring to the world and to our understanding. And I think there are just many different purposes that it has. One is it can directly impact individuals, like in the case of tuberculosis. It can mean that people get earlier treatment. It can reveal long-term trends or patterns in diseases. It can help identify emerging outbreaks or new problems. find disparities and targets for new interventions. We can also use it to track progress. How fast is progress happening? We can answer empirical questions on how effective policies are or how effective technologies are. We can also use it to guide resources and to know where people need the treatments that we have. And finally, we can use it to shape perception. People's perception can affect the decisions that they make and what they think are important problems. So data is something that I think a lot about because I work at Our World in Data, and people often come to us for questions about all kinds of things, like the population size of countries, the causes of death, poverty rates, and everything else. We bring together data and research on very big problems to explain these empirical patterns and trends. And one thing that I've learned from working at Our World in Data is that when it comes to official data, most of the world is in the dark. One example is just the number of births that happen in each country. In many countries, a large share of births are not recorded officially. And this is really important because it informs our estimates of the population size of countries. The population size might seem like, okay, it's just a number, but it's used as a denominator for many other important things that guide decisions. This problem is even larger when it comes to things like causes of death. In regions like Africa and South Asia, most causes of death are not recorded officially. This could be because of a lack of hospitals and medical records, or it could be a lack of doctors and nurses with the training to fill in a death certificate, or it might just be because people are dying outside of hospitals far away where people actually don't know what they died from. And this lack of data leads to very wide uncertainties sometimes. You might know this from the example of the pandemic. So for example, we were trying to estimate the number of excess deaths that occurred during the pandemic. And this was more than 4 times the number of confirmed deaths from the pandemic. You can see very large uncertainties, but even this lower bound is 3 times the number of recorded deaths. So given all of these limitations and all of these, this lack of data, how do we even know what's happening in poor countries? So sometimes the answer is there are efforts to collect data on particular areas. One example is trachoma. Does anyone know what trachoma is? Maybe you could raise your hand. Oh, great. So trachoma is this very painful eye infection that's caused by a bacteria. What happens is the eyelids get inflamed and they start to turn inwards. Then the eyelashes start to turn inwards and the eyelashes start to scratch the cornea. After many years, that can lead to blindness. But it's very easy to prevent with antibiotics in the early stages of the disease. And in the middle stages of the disease, it can be treated with a simple surgery. So in the 2000s and 2010s, there has been a global effort to try to reduce the prevalence of trachoma. That involves more than 1 billion doses of an antibiotic called azithromycin and millions of eyelid surgeries in the countries that it affects. You can see that there has actually been a lot of data collected on this topic for the purpose of reducing the prevalence of trachoma. That involved a project called the Global Trachoma Mapping Project. This involves eye examinations of more than 2.6 million people in 35 countries that was helping to diagnose early stages of trachoma in young children. You can see some of the prevalence rates here are quite high. There are some regions where more than 20% of kids have the early stages of this eye infection. This mapping project was funded by USAID and DFID, the foreign aid departments in the US and the UK. And it determined how many antibiotic doses were given out to children across these countries. After the program, the second map shows the most recent surveys. You can see a very large decline in the prevalence of trachoma. There's more than a 90% reduction in the number of people at risk of blindness from the disease. So this was a very ambitious and successful project. And projects like this to collect data and map the world are often funded by foreign aid, or the data is collected by nonprofits, NGOs, or sometimes by crowdsourcing, like with OpenStreetMap, which you might have heard of. There are also broader systematic efforts to collect data across many areas. One very prominent example that I wanted to bring up was the demographic and health surveys, which you might have heard of. It's primarily funded by USAID. And this was launched in 1984, initially to focus on fertility data, so number of births, but also women's childbearing decisions. By now, it has actually involved more than 400 surveys across more than 90 countries around the world. And what's important here, I think, is that some of these countries are the countries that lacked a lot of this data in the past. These surveys involved interviews, collections of biomarkers like lead and nutrition, and then GPS data that allows people to see geographically exactly where these problems or where diseases are more prevalent. So you can see here the different types of topics that are covered in the demographic and health surveys. And I wanted to bring this up because I think that this effort is actually exceptional. The demographic and health surveys involves large nationally representative samples in countries that it occurs in. More than 5,000 to 30,000 households are interviewed per country. It's also very rigorous. There are standard training and manuals. There are issues with the data collection, like interviewer bias. Sometimes the interviewers don't want to complete the whole survey because it's too long. But this is well studied by researchers who use it. And there's also a lot of other benefits. There's geographical data, and there's very high participation rates of people in these studies. What's really important about this is that they're collecting data in exactly the places where it was previously missing, and it functions as this independent and standardized source of data in many countries. In fact, in many places, it's actually the only national data source that they have on topics that we are interested in. So this map shows the countries in the world where the demographic and health surveys is the only source of data on maternal mortality. So if there's no birth registration or no death registration, well, the demographic and health surveys might be collecting that data. And in fact, if I think about many of the data sets that we rely on at Our World in Data, so from maternal mortality to child mortality, population sizes, water, sanitation, and hygiene, but even things like poverty, urbanization, energy access, education, human development, all of these are partially fed into by the demographic and health surveys. And the reason I'm bringing this up is because it's no longer running. In February, the demographic and health surveys was terminated. And I think this was part of a larger effort or skepticism around data collection and its value. And it's particularly sad because there were several surveys going on at the same time while the survey was terminated. So 23 surveys were actually ongoing at this point. And in 10 of them, the data collection had already been completed. The final report and the data are unavailable, even though all of that effort has already been made. So this is particularly inefficient. The other reason that this really matters is because there was already a gap in data collection during the pandemic. You can see that here. So there was a big drop in the number of surveys completed during the pandemic, but now this pipeline to bring back that data is broken. Now, we've already seen a large reduction in foreign aid spending in the US and other European countries, and lots of people are thinking about how to use the remaining aid more efficiently, trying to understand how cost-effective remaining programs are. Well, I think this makes that process even harder. We need data like this to understand what the population sizes are, but also to track the diseases that some of these programs are targeting. All this makes me think that data collection is an intentional act. I think many people might take it for granted. These are just numbers, they kind of exist. But it really requires lots of effort and people deliberately going out there to collect it from people around the world. So I have a few takeaways from all of this. One is that data has many uses. It brings value in lots of different ways, often that can't be anticipated in advance. Second, collecting data is an intentional effort. Third, collecting rigorous data at scale is possible in the poorest parts of the world. And fourth, it changes our understanding and priorities. It helps us spot emerging problems. But bigger than that, I think there's a greater tragedy of having missing data. Every year, millions of people suffer and die from diseases without any details about those deaths being officially recorded. And this limits our ability to learn from them and prevent suffering in the future. So by collecting data, by fostering the institutions to collect that data, I think we can make every death or every life count. Thank you.
So, Saloni, first of all, thank you very much. That was very, very insightful. Now, I know that everyone in this room is very interested because, they're here. And a lot of us have, at one point or another, used this data. I speak from experience because you and I have collaborated on a project before where your data inputs were very useful for informing the campaign that we ultimately took as an intervention on malaria. So would you say there are specific examples outside the the other three that you gave on where health data has actually resulted in decisions and policies being implemented or being put in place?
Yes, there are several different examples or ways that you can think about this. One is like causes of death that I mentioned. So collecting data because we don't have official data on the causes of death, there have been surveys called verbal autopsies where researchers go to households and they interview family members to ask, did you have a relative who died in the last 6 months? If so, what were their symptoms? And based on that, they try to determine the causes of death. And that's led to better understanding of some diseases which previously were thought to be rare, but it turned out were quite common. So one example is deaths from snake bites in India. Around 1 in 200 people dies from snake bites in their lives in India, which is much higher than a lot of people thought. Another is childhood drowning in Bangladesh and in India. That again was more common than people thought, and I think the final one was tuberculosis. And what's common between these is that it was generally disproportionately seen in people who lived in rural areas, living far away from hospitals. So they were the least likely to be recorded by official data that relies on that. So that's one example, and then there are other, so basically this knowledge led to differences in funding priorities. So they're now funding projects for better anti-venom to treat snake bites, but also Bangladesh and India have implemented kind of school-based swimming lessons, for example. And then there's more effort on developing TB vaccines. But then there's also, let's say, outbreak surveillance, right? Collecting data actually means that we can guide people to control outbreaks in specific areas better. So that's another example.
Thank you. So from what you have mentioned, I think there's also what I imagine is a cost-effectiveness angle to this, because a lot of the decisions that we make in terms of where we want to put our resources, there's always questions on whether that money can be spent somewhere else better with greater impact. So this is going to be a two-part question. The first one is, do you think that data collection is cost-effective? And the second part being, do you perhaps imagine a world where philanthropies or just funders could allocate more funding towards data collection as a precursor for informing where money should be spent?
Yeah, so I think it's hard to measure the value and the cost effectiveness of data collection, as I mentioned. You can measure it for specific outcomes that you care about. So with the TB example, if you're interested in collecting data for a specific use, then yes, it should be possible. And then obviously there are different questions of like, if you want to collect this data, what is the best or cheapest way to collect it in an efficient way? And sometimes the cheaper tests, like let's say the rapid tests during COVID, might have been a better idea than relying on more expensive PCR tests. But another point is that basically, many of these other interventions that people are interested in depend to some degree on the data collection to know if they're cost effective. So if we want to understand or decide on prioritizing other projects, then I think this data collection is really valuable for that reason.
That's good. And maybe to segue from that particular point, you, in your presentation, covered on the demographic health surveys that, as you mentioned, was running in like 90 countries and currently does not exist. I think there's a question in the Q&A which is trying to find out, I don't know if you have data on the total funding budget that was going to the demographic health survey, but the question is whether or not this can be restarted by external funders.
I think, it's quite a large project, so I think from what I understand, it's roughly some 40 million per year or so, and so one of the projects for the last 5 years or so was around $250 million. So that's quite difficult for like one funder to do, to be able to fund. I think there's kind of a question of, these initial surveys that I mentioned that were ongoing, and some of them were already completed, and trying to just get those to the finish line and have those public, that's probably quite an easy short-term goal to get funding for. Whereas like trying to fund it in the long term, I think needs a lot more people interested and aware that this is important.
And that's very useful. So let's maybe live in two worlds. The first world is a world where we are still waiting to get a lot more people, perhaps governments, to declare interest in funding, which I think is a very important aspect of how we, think about health and where we should be thinking the issues are. Because I've personally used the demographic health survey data, and you are right to say that in some countries, especially in Africa, it's the only data on so many things, right? Now, putting that word aside, do you perhaps have a figure on what would be an estimate of the optimal percentage of aid money that should be spent on data collection? This question is coming from the Q&A.
Oh, wow. I don't have an answer to that. I wish I knew. I think data collection is really important, but I'm often, when people ask me, what should be collected, I'm also thinking about what is a less expensive way of collecting the data that we need. I think there are basically differences in how efficient this can be. But I think beyond that, I wouldn't be the right person to answer. Thank you.
So I'm also going out on a limb here and just going to assume that a lot of the work that you do, our world in data, also involves trends, predictions, algorithms, and things like that. So when we start talking about those kinds of things, I think there's a natural thought on to what extent, AIs coming up and what role they could have in, data collection. This also is coming from the Q&A.
Yeah, I've been thinking about this as well. I think there are. Let's say, with a usual questionnaire these days, there are often specific questions, and you're asking like yes or no questions, or you're asking for people to specify specific things, and then based on that, you might be extracting other information. So one example is like you might have a question about depression, and then you have some 12 questions about depression, and you score them, and then you try to estimate whether the person has clinical depression. And now I sort of have been thinking, what if we just give people an open-ended question? Maybe we give them a minute or two to talk about what their mood is like. And I think that probably LLMs could be quite good at using that to infer their level of depression in that time period. So that's one use. I think there are also other uses of AI in kind of helping people analyze this data at scale, just because of how much data is being collected. For example, with these interviews where you're interviewing people on their relatives and what symptoms they had before they died. I can also imagine AI being really useful in trying to classify those causes of death based on people's answers.
Well, thank you so much. So I know we are running out of time. We only have 2 minutes left, but I'm also very curious to try and understand from your perspective. I think a lot of the global health data is usually most useful in countries with high burden of disease. And if we're picking a region, I would say Africa perhaps has, a region which has the highest potential application for this kind of data. But I also understand that it's also one of the regions with the lowest contribution to actually, verified data, as it were. How do you navigate this when you are collecting data?
I mean, I basically agree that I think, if we had to choose, that seems like the priority. And also, I think in other countries, there has been more of a move for governments to start collecting this kind of data more regularly. I think what's very helpful with, for example, the demographic health surveys is that they function as like an independent source that's collecting this data in a standardized way across many countries on some of the same questions. And that means that both that model is very useful in terms of organizing it, but also in terms of comparability. So that's what I would pick as well.
Well, thank you so much again, and this is a very interesting conversation. We could keep going and going. Maybe just one last question, and then we can wrap this session. So there are people who've asked in the Q&A. They're very curious. Is there a way that perhaps people in the EA community perhaps could contribute to fostering a more resilient and sustainable data collection effort, specifically in the LMICs?
Right now, I think that basically the demographic and health surveys is the main source of this, because they also collect data on many other issues. So if you're interested in, let's say, a topic that doesn't already exist in it, it has basically grown over the years to collect data on all of those other issues as well. And I think because it's this independent org that does that and is used to doing that, that seems like a great source. So I think trying to find ways to get it funded again or find ways to save parts of it are going to be really important. And then I'm not super sure how effective altruists could contribute to that. Maybe that's through advocacy or just trying to connect people with funders, or trying to bring this up as clearly important for so many of the different areas that we care about. As I showed, many of the estimates that we rely on at our role in data ultimately are influenced by this data.
All right. Thank you so much, Saloni Dattani, and that's unfortunately all the time that we had. But in case you have any questions or follow-up, Saloni is available for the next half hour, right?
Right.
Yeah, so I just want to say once again, thank you so much, Saloni, for the really wonderful and insightful presentation, and to our audience for sticking with us through these last 30 minutes. Otherwise, thank you so much. This is where we wrap up.
Thank you.